So thank you. I would be talking to you about the biosynthetic cornea that we are working on. And this has become important because we know, as per the recent survey, corneal opacity is the second commonest cause of blindness in our country after cataract. And in the age group 0 to 49 years, it is the commonest cause of blindness in our country. So, would just like to begin with the corneal ectasias, where you do lamellar keratoplasty. In some of the cases, can be really tricky, and this is just a prelude to show that suturing in these cases may be a little difficult. Uh, for instance, if you see in this case here, if you have to suture the periphery, then you have to go right till the periphery over here, tuck the graft in, and if it is excessively thinned out, then this can be a little problem. We do require 2 lakh corneas. We collect only 52,000, transplant 25,000. So there is a huge disparity between what we collect and what we transplant. Possibly we don't even have the numbers of exactly how much we need. And in the COVID times, it did decrease further, and we've still not come to the level where we were in the pre-COVID era. So there is a need for biosynthetic cornea. The limitations of human donor cornea are limited supply of the donor cornea, risk of graft rejection, post-op complications associated with sutures and wound healing, risk of corneal neovascularization and or infection, astigmatism after suture removal, need for long-term topical steroids, and necessity for long-term patient follow-up. The biosynthetic material that we worked on is a bioengineered porcine construct, double cross-linked. It is a clinical grade collagen type 1, and it has been cross-linked using cross-linking agents. And basically, this is how it looks. And it is quite transparent, something like a soft contact lens. It comes in 12 millimeter diameter and varying thickness from 100 to 500 microns, and has a shelf life in the bottle for 2 years. Uh, it has undergone all the quality check tests that are required, like optical and mechanical properties, enzymatic degradation, in vitro cell bioavailability, and stage UVC radiation sterilization, biological safety, shelf life stability test, as well as in vivo biocompatibility test and ex vivo analysis in mini pig keratoconus model. So we look at the transmission, and here it is comparing the two. One is the biosynthetic porcine construct, and other is the biosynthetic porcine construct, which is doubly cross-linked, as well as the human cornea. So it is light transmission is almost the same as that of the human cornea. And if we compare the scanning electron microscopy, it will show tightly packed collagen fibrils in the BPCDX cornea, with the slightly thicker fibrils as compared to the native porcine corneas, as can be seen here. Subsequently, if you see the epithelial adhesion, the control here is a plastic on which the epithelial cell adhesion is being evaluated in BPCDX. The adhesion is quite good, and there is greater cell density than the cell culture plastic ware. In the animal studies, again, this has been compared with the autograft, and it does compare very well with the autograft when we compare it with the BPCDX, both in terms of pachymetry as well as in terms of corneal curvatures, and also in terms of the confocal microscopy. And also, this is to show animal study of the autograft. So this is the native, this is the autograft, and this is the BPCDX, the epithelium and the stroma. Again, you can see that in the immunohistochemical analysis, the subbasal nerves by beta 3 tubulin marker show preserved stromal nerve in the BPCDX cornea. And this is how the surgery is done. There is nothing too much to it, except that you do require a femtosecond laser to make a pocket. And once this pocket is made, this can be opened up with the help of the lamellar dissected, and this is how it comes. So you have to triffinate it according to the size of the pocket that has been made, and either one can just place it, or if you made a smaller incision, then just fold it like we used to do the older lenses, which used to be folded with the forceps, and just then unfold it inside and place a bandage contact lens. You do have a little bit of corneal edema in the first post-operative day, which subsides over a period of time. This is another case of keratoconus with pellucid marginal degeneration, where the thinning is there very much in the periphery, and there is also a cataract which is there along with it. So in this case, again, the femtosecond laser is being used to make the pocket. And you can go right up to the edge and right up to the periphery here. The offset that you have to keep is about 120 microns at the of the recipient, so that if it is more, then there are chances that the laser may not fire adequately. And then this case was subsequently taken up on the intraop OCT microscope. Again, this pocket which was created was reinforced with the help of the lamellar dissector. And then the biosynthetic cornea was placed inside after measuring its size. And because this patient also had a cataract, so 3 months down the line, the cataract surgery was also done. And it is quite clear, and you can do the surgery very well, except the rim that is there, which is seen, it otherwise is quite clear, and there is no problem in visualization. Now this is again the case 2, and you can see the sandwich biosynthetic cornea inside, which is present intrastromally. This is the third case, again very severe keratoconus. So when you do put a intrastromal synthetic cornea, there might be some folds which may be there in the immediate post-op period, which over a period of time do become all right. And this is just to show the same case, Kmax of 85.9 diopters and post-op Kmax of 57.1 diopters, and it has become a in regular pattern as well. And this is our longest follow-up, so all you see is this rim which is there, and otherwise it remains quite clear. Now very recently we've used this also for a case of post LASIK ectasia, and this is the case in which the flap is elevated, and after elevating the flap, what is done is the biosynthetic cornea is placed. Notice that it is so thinned out, the recipient bed, and possibly that is why ectasia has been caused. The pocket is again reinforced all around, just we've described tuck-in lamellar keratoplasty for these cases. And after doing this, the biosynthetic cornea is placed, and you can see how thin out the bed is, and possibly that is why this ectasia has occurred. In this case, you can't leave it unsutured, you have to suture it because the flap becomes edematous, and after suturing it, one can again place a bandage contact lens. Now this is in the post-op period, and notice again it is so thinned out, the bed is so thinned out, and this is again a Kmax of 89 dropped down to 50.4, and pachymetry of 241 increased to 581 microns. So sometimes you can have situations like this where you can't use a femtosecond to make the pocket, but you can use a microkeratome to dissect it, and if it is hazy, you may even have to address it manually. This is the biosynthetic again cornea, which is being placed after triphinating it into the correct size, and then all you have to do is just glue it, and after gluing it, one can place a bandage contact lens. I like to always put the bandage contact lens in a reverse manner, because I feel that gives a little tighter fit, and after doing this, this is the post-op picture. These cases do take a lot more time to epithelize. It takes about 7 to 10 days to epithelize, because it has to epithelize on the onto the synthetic cornea, but over a period of time it remains quite stable. So these are our results. Now we've done in 50 plus corneas, and all patients had good visual acuity with no rejection, inflammation, vascularization, or scarring in any of the patients, and the mean pachymetry increased from this was actually done in 2 cohorts, one in Iran and one here. So the mean pachymetry improved in both the cohorts, and Kmax also showed a decrease of 11 diopters in Iranian and 13 diopters in the Indian cohort, with the best corrected visual acuity, which was quite good. And these are the results which were arrived at 48 months. Now, if you look at the epithelium and the Confuscan pictures above and below it, then they appear to be quite normal, and this is too far-fetched. We are not going to get rid of eye-bank corneas, but this is one step towards it. Possibly may not require, if we are able to grow endothelial cells on this, all this paraphernalia. So there is a feasibility of distributing these corneas. It is potentially safe and simple surgical procedure, not dependent on human donation, no graft rejection, suture-related problems. And it does not preclude a human graft transplant if required. And what I think reality is going to be complete corneal construct. This was just the stromal construct when you could grow endothelial cells on them, which again is a very difficult task. This results of this study were published in Nature Biotechnology, both the Iranian cohort as well as where the impact factor is 68.1. So to conclude, use of bioengineered corneas for intrastromal keratoplasty is feasible, safe, and simple technique. Of course, we do require longer follow-up, and a larger number of cases and maybe more variety of cases is required to conclusively say so. So this is just to show how, just like intraocular lenses, you put them, and I mean you use them from the wrap. I hope something like this happens to the corneas also in the near future. My acknowledgements to our collaborators in Sweden and Tehran, with whom we've been working, and thank you very much for your kind attention.
Thank you, madam. Uh, One question. The last case which you showed, where you did an ALTK, the graft or the artificial cornea, was it fixed with sutures or just glue?
It was glued.
Just
It was
glue.
not fixed with sutures. Suturing this cornea is very difficult. It cheese wires, and to pass a suture is difficult. Then for the sutures to stay there is difficult. So as of now, you can only glue it or put it intrastromally.
Subsequently, you've also noticed that the biosynthetic cornea gets populated with the cells in postoperatively.
It remains acellular essentially. Over it, you can see that the cells are there. I mean, on the confo scan, we could pick up the cells and the nerves. Below it, and the endothelial cells could be seen. But if you see, even in the animal studies, when you compare it with the autograft, it remains acellular. There are no cells in it or nerves in it.
And what's been the longest follow-up? I'm sorry, I'm not
So
sure.
the longest follow-up is now 6 years.
6 years.
Geeta, can I ask a question? Dr. Namrata, fantastic, mind-blowing work. The only question that comes to my mind is I had this when something similar was presented by the LVP group also, that normally in an eye bank we don't use each and every corneal tissue. There is always some amount of subclinical tissue or suboptimal tissue that we do not use. And if COVID has taught us anything, it is not to waste tissue. At that time, we used to glycerol preserve it, make it acellular, and diversify the usage. And suppose we adopt such a very stringent principle of not wasting any tissue at all, and those which are not optimal for surgery, we all the time decellularize it with glycerol or any other means. Then wouldn't it be just would we really need a stromal construct after that?
So it would depend on what you decellularize it with it. If you do it in glycerine, like glycerine preserved corneas, then of course those corneas are very thick, and you would possibly have to split them. And I don't know whether they are clear or not, because they are not going to be clear. I think they are going to be opacified. So that is a challenge. I think you can do it with anything, but then at least that material has to remain clear.
So the fineness of tissue is better with this than those
Yeah, this
things.
is clear. It is acellular, just like your glycerine preserved cornea, but it is clear, so the patient sees through it.
Right.
Thank you, madam.
Thank you.